Hello, and thank you for viewing this training on Quality Improvement 101. I'm Rachel Wallace-Brodeur from the National Improvement Partnership Network based at the University of Vermont. This training was developed for the Washington Department of Health AFIX Program. And our agenda for this training is we'll begin by reviewing the rationale for using quality improvement to improve clinical care. We'll introduce a quality improvement methodology, and then finally we'll give you some tips for getting started. I want to start with the definition of quality improvement, and this definition is from William Riley and et al.'s 2010 paper about quality improvement, and they define it as a continuous and ongoing effort to achieve measurable improvements in the efficiency, effectiveness, performance, accountability, outcomes, and other indicators of quality services or processes which achieve equity and improve the health of the community. I really like this definition because it really captures many of the components of quality improvement. So why do quality improvement to improve clinical care? Well, research has shown what interventions really do promote changes in clinical care. And what that research found is what does not work is just providing educational materials to health professionals or the traditional CME type trainings, which are didactic educational meetings. They identified some things that work variably, and that is audit and feedback to practices alone, opinion leaders, input from local opinion leaders, developing the local consensus process, or patient-mediated interventions. What that research found does work consistently are strategies such as academic detailing, reminder systems, both manual and computer, multifaceted interventions such as a typical quality improvement, and what those multifaceted interventions are, 2 or more of these activities: audit and feedback, reminders, local consensus meeting, marketing. And then finally, interactive educational meetings or workshops are also effective in making change. So a typical QI would have many of these in place, such as the academic detailing might be there, the interactive educational meetings, as well as several of those other strategies. So there are lots of different models out there for quality improvement. There's a model for improvement. There's FADE, which stands for Focus, Analyze, Develop, Execute. There's Lean Six Sigma, and total quality management, as well as others. But all these models share the same basic principles, which are quality improvement is really incremental, based on incremental change. It needs to be driven by data. It needs to be done in an environment for shared learning that involves teamwork and open communication. It's about systems and processes, and in the health venue, we're talking about individual and population health outcomes, and it's about sustainability of those changes. So when we talk about changing systems, there's the adage that every system is perfectly designed to achieve exactly the results it gets. So if you want to improve, you must change your system. So the goal in quality improvement is to really move the system from a current state of performance to a new and improved state of performance. So now I'm going to review one of the models for quality improvement and what that methodology would look like when it is implemented. The model we use most frequently in our work with clinical practices is the model for improvement. This model is from the Improvement Guide by Langley, Nolan, Norman, and Provost. And this model illustrates the components of it. So it starts with, what are we trying to accomplish? So what is the aim of your improvement work? And then how will we know that a change is an improvement? That's where you base your measurement in your project out of? And then what change can we make that will result in improvement? So you develop a change strategy, and then you'll implement that through plan, do, study, act cycles. And we'll go through each of these components in more detail. So these are the steps you would go through in undertaking an improvement project. So first you would assemble your change team. Once your team is together, you want to develop an aim statement that everyone agrees upon. You then develop a roadmap for how you plan to achieve those outcomes. You'll determine your measurement strategy for how you'll know when you've reached your aim. You'll identify what strategies you want to test to make an improvement, and then you'll implement those strategies using the model for improvement. So things to think about as you develop a change team. You want to have all the team members who have a stake in the outcome. So we really encourage folks to develop cross-functional teams. So in a clinical practice that's focusing on improving immunization rates, you want to have everyone in that practice who has a role in immunizations engaged at that team. So that might be the provider, medical assistant, nurse, if there is an internal quality improvement specialist or immunization specialist, front desk people. So if you bring in all those different perspectives, you are able to better function, make sure those who are engaged have a voice in the process, and everyone has a different perspective, and that perspective is really valuable as you think about making improvements to a system. And no one individual has the sufficient knowledge to solve the problem. And we know how hard it is when one person decides they're going to change it. They come up with the idea, force it on people. It's very hard to get by-in that way. Other people coming from different perspectives may be very critical of the idea, and it will be hard to implement. And when you think about developing your team, a really effective improvement team is one that's flexible. So folks are willing to change and respond to what they observe is happening, and ready to adapt when something unexpected happens. And really, to be creative and solution-oriented is very helpful as well. So after you develop your change team, you want to start thinking about your aim. And your aim is really, what is it you want to accomplish? So to do that, you want to picture the end result. And when I think about aim, I always think about a quote that Don Berwick made in 2004 as he was kicking off the 100,000 Lives campaign, when he said, "Some is not a number and soon is not a time." And with that in mind, you always want to think about your aims being SMART. And you may have seen this. This is a common acronym for goal setting or setting aims. So SMART stands for specific, measurable, attainable, or sometimes you'll see achievable, relevant, and time-based. So a sample aim statement for HPV immunization could be something like this. By September of 2018, we will increase the rate of HPV vaccine series completion by 10% over our practice baseline rate. So that meets all the criteria of a SMART aim statement as something that's very measurable. You have a time-based goal, and depending on what your practice baseline rate is, you might decide whether 10% is realistic or reasonable or not. So after developing an aim statement, you want to develop a roadmap on how you're going to improve or achieve those outcomes. A very common tool used to do this is called a key driver diagram. And this is really a tool to help understand your systems, its outcomes, and the processes that drive those outcomes. And when we think of a key driver diagram, this is really the best theory of how you might achieve the desired results. And talking about key driver diagrams, we talk about two different types of drivers. There are primary drivers, and those are the system components that contribute directly to improving outcomes. And then there's secondary drivers, and those are elements that help create change such as those interventions that are expected to affect those primary drivers and hence your outcomes. So here's a sample key driver diagram. This is from a 2014 pediatrics article. And this is about improving immunizations. So the aim in this key driver diagram is to reach a 95% immunization rate for patients aged 24 months. Here they color key drivers, which would also be primary drivers, systemic identification and capture of target patients, use of a patient tracking registry, and then patient outreach and care coordination. So then on the right hand, you see those components or secondary drivers that would impact those primary drivers, things such as checking immunizations, creating a registry to track who's under immunized, performing outreach and care coordination, etc. This is an example of a key driver diagram specific to HPV vaccine, and this key driver diagram was developed for a project NIPN did with the Academic Pediatric Association. So in this key driver diagram, the key desired outcome or aim was to improve HPV vaccination initiation and series completion rates in participating clinics from baseline to the end of the study by 10 percentage points. So the primary drivers we identified for this work were a lack of knowledge about the benefits in the public or fear about HPV vaccine, lack of acceptance or standardization among providers in offering HPV vaccine. Adolescent immunization is not a part of workflow. It's easy to forget. And finally, physician knowledge of performance in terms of HPV vaccine. And then the interventions we focused on were strong provider recommendation, parent and patient education, and community outreach. Looking at consensus within a practice for all providers in clinic as far as how and when they'll administer the HPV vaccine and posting those standards in the clinic. And then strategies for making it part of the workflow, such as adding it to HPV vaccine to well visit templates, having provider prompts at all visits, including sick visits, and then having standing orders for the vaccine. And then important in any quality improvement is really looking at your data. So after you develop a roadmap for how you might improve or achieve outcomes, you want to determine a measurement strategy. And measurement is really how you will know when you've accomplished your aim. So these are two of my favorite quotes about measurement. Lord Kelvin said, "To measure is to know. If you cannot measure it, you cannot improve it." And Edward Deming, another figurehead in the role of quality improvement, said, "Without data, you're just another person with an opinion." So when we think about data for improvement, that data is typically collected to observe how your process is performing. It's to obtain ideas. Where are there gaps? Where are there successes? And to identify ideas for where you might make some changes. It's to test changes. And then finally, it can be used to determine sustainability once a change has been implemented. When we think about measuring for improvement, it's very different from measuring for research or for accountability. And these tend to be areas that people are more familiar with. So often when you talk about measuring for quality, there can be a big misunderstanding there. So we're measuring for improvement. We're looking at we're doing really short cycles of improvement, and we want to look at just enough data to be informed by what happened in that cycle of improvement. We're usually looking at data that's readily available, so we don't want to find something that's very difficult to obtain. So for a practice, it might be looking at data that's in their EMR or perhaps in their immunization registry. A key thing for measuring for improvement is that the data is for learning, not for judgment. And I heard at a conference once someone say, we're looking at this data for light, not for heat. So it's really important to think that this information really is for education and learning, not for punishment, not for accountability. It's not about judging. And with that in mind, failure is good. And I love the Thomas Edison quote that said, I haven't failed, I've just found 10,000 ways that won't work. When you're looking at data for improvement, you really want quick turnaround on that data so that the information is meaningful to the practice in real time. And then typically data for improvement is plotted in run charts, just shown on the bottom here, so that you can view that data over time. I'm going to go over quickly 3 types of measures that we often think about in quality improvement. And those are outcome measures, process measures, and balancing measures. And each look at different components of a system. So outcome measures are really looking at the change in individual or population health outcomes. And those can be intermediate or long-term. And I'll go through examples of each of these in the next slide. A process measure is really looking at how the system is functioning. Is what we think happening? Did the change we implement, is it being implemented the way we thought it would? And then finally, balancing measures are measures that look at something unintended, sometimes adverse, that is happening elsewhere in the system based on the changes you've made. And for anyone who's done a maintenance of certification project, you know that application for those projects requires all 3 types of these measures. So here's a sample of each one of those types of measures. So again, we're using the example of HPV vaccination. So a sample outcome measure for HPV vaccination could be the percent of 11 to 12-year-olds who received 1 or more doses of HPV vaccine. A process measure might be, say the process is trying to increase those rates by implementing a reminder recall system. So a process measure is going to be around that reminder recall system. So it might be what percent of those practice 13-year-olds who are overdue to start the HPV vaccine received a reminder notice from the practice. Or it could be what percent of those patients made an appointment based on that reminder notice. And then finally, balancing measures. Say, for example, the site starts administering HPV vaccine at all types of visits, not just well visits, but also at acute visits, chronic care visits, etc. Well, many practices fear that doing that will result in the adolescent not coming in for a well visit check, because often receiving immunizations is an incentive for an adolescent to come into that well visit. So if you're giving vaccines at all types of visits, is that going to impact your well visit rate? So a balancing measure might be to look at what percent of 11 to 12-year-olds have a well visit check. Does that change as you implement other strategies to increase HPV vaccination? When I think about quality improvement and this model for improvement, there's really 2 levels of measurement. So I think of the project level measurement being those big measures. So for example, the increase in HPV vaccination rates. That's a project measure. When we get down to the level of what change can we make that will result in improvement and doing these plan, do, study, act cycles, you're really looking at smaller measures that the practice can look at more discreetly, so it might be some of those measures more process related as they implement a strategy. And I'll talk a little bit more from that. But again, they're really to inform individual PDSA cycles. You want that quick feedback and able to collect it easily. And often this might involve manual data collection, just doing tally sheets, anything like that to get some quick feedback. So once you've determined your measurement strategy, that's when you start thinking about, well, what strategies could we test to make an improvement in our system? And again, I love this quote by Ferdinand Porsche: change is easy, improvement is far more difficult. So another quote we often say in the quality improvement world is that all improvement requires a change, but not all change is an improvement. So you really want to be identifying what strategies you can make that will be an improvement, and that's why your measurement is so important. So here is some of the strategies that you would find on the AFIX from an AFIX visit. These are all good strategies, and as you're doing your AFIX visit, you'll be working with a practice to identify what one of those they might want to implement using a quality improvement model. Sometimes identifying which of those they want to implement really requires understanding the current process first. So you may have heard the term root cause analysis or process flow mapping. These are two different tools that really can help sites understand their current system. And I'm not going to go into great detail about those processes in this webinar, but I will talk about briefly about the steps to understanding process. So you'd have your change team, and they would talk to all the stakeholders in a process in there to understand the underlying system. You want to map out that current system and identify the problem. Where is the gap? Or if you're implementing a new process, it might not be where is the gap, but where can we add this additional step into our current process? And then identify change that fits the problem. So one way we do this is by process flow mapping. And you'll define the process to be diagrammed, and you really want to decide upon the boundaries of your process. So as a group, you define, well, where does it start and where does it end? So for example, in the example of immunizations, does it begin when the patient walks in the door to the clinic? Does it begin when a patient is contacted to make an appointment? Where is that start point going to be? And then as a team, you would decide what level of detail you want to include in the diagram. So these can be incredibly detailed or complex, or they can be larger ideas and slightly more simplified. So then the multidisciplinary team would brainstorm all the activities that go into that process. And you want to write one step. We typically use sticky notes. You can use index cards, doesn't really matter. But you're going to write all the activities that go into that process. After you've done that, you're going to collect all the stickies and you're going to arrange them in proper sequence. So from start to end of the system. Then very simply, you draw arrows to show the flow of the process. There might be decision points by which there could be two different paths or more than that could be followed. And then everyone would review that flow chart for accuracy. If yes, they're going to make an appointment for that child to receive the vaccine. If no one answered the phone, you'll leave that scripted message on the answering machine. If they call back, again, you make that appointment. If they don't call back, you're going to add the patient to a tracking sheet if there's no response to the message within a few days, and they would then be called again. Here's another example, not related to immunizations. This is related to developmental screening, and with this one, I like to focus on the bottom left-hand corner. So it has the steps, fairly simple steps in doing developmental screening in a clinical practice. But what I like is these steps you do at the end. And it says, for each step, ask, can it be eliminated? So is there a step that is not necessary? Can it be done in a different order? So would things be more efficient if we switch this order? Can it be done by someone else who's maybe more appropriate, someone who has more availability? Are there any unnecessary waits in this process? Are there communication breakdowns? Does this step add value to the patient? And does it add value to the staff? So that's a good first look at any processes. And I like this for several reasons, because one, a lot of times when sites are implementing quality improvement, they don't feel they have time to make changes? Well, sometimes you don't have time because the current systems are not perhaps as efficient or effective as they could be. So doing this process flow map can be a first step in identifying ways things can be done more efficiently, as well as identifying where you might need to make changes and add new steps. So after you've identified the strategies you want to test, you're then going to implement those strategies using the Plan, Do, Study, Act cycle. The Plan, Do, Study, Act cycle, or PDSA cycle, is really how improvement happens. So it's 4 simple steps that are repeated over and over again when making improvement. So in the planning stage, you're making questions or predictions about what you think might be happening or what could happen. And you're thinking about who, what, where, and when. So that's the planning, is who's going to do what and where and when are they going to do it. And you're going to develop how are we going to measure our plan, measure this activity. The do phase is just as it sounds, you're doing it. But while you're doing it, you're documenting any problems, unexpected observations, or even expected observations. After you've done it, you really want to take that time to study it. So what worked and what didn't work? So some of this might be qualitative information. So this might be information that folks noticed it or heard from patients as the test was being implemented, and then some of it might be quantitative. So we actually kept track of how many patients said yes to the vaccine when we did this, and you have that data. You want to compare what came out of this to what you thought was going to happen, and then as a group really summarize what you learned from that. Then you'd move on to the act phase. And this is when you really think about, well, what are we going to do based on what we've learned? And sometimes folks refer to the act phase as the adopt, adapt, or abandon phase of the PDSA cycle. So based on what you learned from testing that strategy, are you going to adopt it? Was it effective and you want to try it again in another PDSA cycle, maybe where you spread it more broadly? Do you need to adapt it? Were there areas for improvement on that strategy that you tested? Or are you going to abandon it? That did not work at all well, staff was miserable, etc. You're not going to continue with that. And then based on that, you'll identify your next steps and do your next plan for the next cycle of your PDSA. So you would use the PDSA cycle for testing or adapting a change idea, for implementing a change, and then for spreading the changes to the rest of your system. So before you start implementing changes, you really want to test changes on a small scale because failure is far more acceptable on a small scale than it is large scale, and it can provide very valuable information. So when we say small scale, we can be talking as small as 1 patient, 1 provider, 1 day. What is that information? What do you get out of that? You then might spread it to 5 patients with 1 provider, and then maybe 2 providers, so on. But you always want to start small. And again, as you kind of go to the next phase, doing that study and act to see what tweaks you have to make to your system. You want to be sure to continue to remeasure to analyze the impact. So as you spread, so say you started with that 1 provider, 1 patient, and you spread to 1 provider, 5 patients, and then 2 providers. At each of those stages, you want to continue to measure to see the impact, because it's going to be different for 1 patient and 1 day, 1 provider, 1 patient, than it is for 2 providers and 10 patients. You want to pilot those results over time under different environments. So maybe during busy times of the day, during quiet times of the day, different provider teams, etc., before you decide you're going to implement those changes and spread them more broadly. So I'm just going to go through a few cycles of a PDSA related to a reminder recall system. So say this practice has fairly low rates of HPV vaccination, and patients just aren't really initiating this series. So they've decided they're going to start by focusing on a reminder, which means they're going to call those patients who've not yet initiated the series to have them come in to get their first dose of HPV. So if they did a query of their EMR or billing system or whatever to identify who had yet to start their HPV series, depending on the size of the practice, that could be a very overwhelming and large list of patients. So you really want to define parameters of how you're going to search that list in a methodical way. So maybe for this test, and maybe moving forward, they decide that they're going to limit it to patients who are turning 13 this month, who've not yet started the HPV vaccine series. So say maybe that generates a list of 80 patients. From those 80 patients, they're going to just pick 10 for their first small test. And they're going to call them and ask them to come in to make an appointment to come in and receive their HPV vaccination. So that's the plan. And then they go into the do. So the front desk person calls patients throughout the day as he has time to try to get them to come in and make an appointment for HPV vaccine. As he's doing this, he's making notes on that patient list of what the response is. So maybe that could include things like number disconnected, left a message, no answer, or appointment made. After he does that, he can then the team can get together and say, well, this is what I found. Some of those numbers were disconnected, so we aren't collecting we don't have the most current phone numbers. Left a lot of message, and so far no one called back. Did get through to one person later in the day who made an appointment. So based on that information in the ACT cycle, they decide, well, what about instead of calling throughout the day, we made those calls later in the day when people were more likely to be home from school or work and able to answer their phone. So that concludes their cycle 1. So following that same practice, their second PDSA cycle might be to call 10 other different patients off that list who are still they're keeping the same parameters, who are turning 13 this month, who have not started the HPV vaccines. But instead of calling throughout the day, they're going to make all the calls after 4:30 p.m. So the front desk does that, and again is making notes as he does that on the patient list. In the study phase, we see some of the same issues that we saw when they called throughout the day. There are some disconnected numbers. They had to leave some messages. People may or may not have called back. But this time, he got through to 4 people, and 3 of those people made appointments to come in for HPV vaccine. However, the other thing he found, it was a lot harder to find time at the end of the day to make that many calls. And he's thinking, well, if it's hard to find time to call 10 patients at the end of the day, how are we going to ramp this up when we're doing a much larger list? So with that in mind, they're like, all right, is there another way we can message patients that will maybe be less resource intensive? So in this example, they decide, well, let's try messaging patients through our patient portal. And that sets the basis for their third PDSA cycle. Now, I'm not going to keep going through this, but as they're doing this, they might be going through these PDSA cycles, they might be generating some very easy data, especially if they're only calling 10 patients at a time. They can know, well, what % of those made an appointment? So no, we're not looking at the outcome yet. We're not saying, all right, how many actually came in and got the shot? We're actually looking at, well, how many appointments were made for this effort we put into calling patients. So you can see in PDSA cycle 1, when they called all day, they had 1 patient or 10% make an appointment. When they called later in the day, they had a much higher response, 30%. And then these are all hypothetical results, but say then they tried messaging through the patient portal, no one responded. So clearly for this practice, that's not going to be an effective way to message. So they went back to calling after 4:30 p.m. and noted that maybe this could be spreadable if we set up a time devoted to an HPV clinic. That way scheduling would go much quicker. So that as I call patients, I could say, we're having HPV clinic on a Thursday between 4:30 and 6. Can you come in for your shot then? When they did that, they found a great response. People were able to schedule. The time for each call went down dramatically, and they decided to adopt this process. Now, some of this is stuff we have learned from our quality improvement project. So as practices in our nationwide quality improvement project implemented strategies, such as reminder recall, we heard things like this from them that, well, we learned we were leaving a lot of messages and no one's calling back. So we thought, well, let's call them later in the day. And sure enough, they had better response. And then a clinic said, it's too hard to find shots only visits. So we're going to set up a clinic with a set time. And when they did that, they found their slots filled very quickly, and they did this regularly. And this gets into when I talked about those two levels of measurement. So here we're measuring at the PDSA level. We're not getting to that measurement of yet is the rate of HPV series initiation improving. We're really looking at that process as you try to implement that new process. All right, how is it going? How many people made appointments? You then might go to the next step of, once you feel like you have a system that's working, all right, now what do our project measures look like? What is that rate of HPV series initiation? Have we seen an increase in that since we've implemented this reminder system? And really, I love this image because it shows kind of a different, when you would implement PDSA cycles, kind of different stages of a process, but they also show the relative kind of size of that PDSA. So really starting with those small scale tests to identify a strategy that might be effective. Gradually expanding those tests to slightly larger as you fine tune them in a variety of different environments and providers. Doing wider scale tests of change, and then finally doing a full implementation of that change to the whole practice and making that change part of the normal clinic flow so that it can be sustained over time. So for successful quality improvement, each PDSA cycle has to be completed in full. And what we often find is that practices are really good at planning and doing, but then that's all they do. Plan, do, plan, do, plan, do. And often they aren't setting aside that time to analyze that data and talk as a group about what was learned, and then go into the act phase and decide what action they're going to take based on what they learned. But those steps are so critical to quality improvement that it's important for a practice to set aside that time. And often in our quality improvement projects, we have some kind of activity that makes them intentionally go through this. So to really report out on particularly that study and act phase of the cycle to ensure that they are following all the way through. And finally, we'll go over a few tips for getting started. So many have heard this quote that a journey of 1,000 miles begins with a single step. And often when practices are embarking on a change to their system, it can feel like a journey of 1,000 miles. And people can get so hung up that they'll never take that first step. So we have a phrase we often use in quality improvement, which is, what can you do by next Tuesday? just to get them to start thinking about, all right, what is that first step I can do? What is the little action that I can do? So if you are at a practice doing an AFIX visit, what you would probably want to do before you left that practice is really make sure they have a plan. So based on the strategy they identified, all right, what might be the plan? What's your next step for that? And then remind them to start small. I have to say a very common error is that practices go too big. So I just talked to a practice that implemented a reminder recall, and in their first recall, they messaged 800 patients. It was a huge resource, and they had almost no response. So failure at that scale can have fairly large consequences. You know, they dedicated a lot of time and resources with almost no payback. The practice was feeling very bitter, not positive about quality improvement at all. With starting small, there's really, you don't lose much if it doesn't work. And if it does work, great, you've learned, and you can try to continue to spread that improvement. So start small, and we also say start with those who are willing. This is not the time to bring in the nurse who is opposed to vaccination, hates change, is very crabby. You want to pull in the people who are enthusiastic and willing, just so that you can get going. And then remember to build in that time to study or act. And this can be as quick as, so if you have one medical assistant and one physician testing a strategy, after that patient leaves, they can debrief for 30 seconds. What worked, what didn't work. That was awkward. I didn't like how this happened. Let's try it this way next time. It doesn't have to be a huge, you don't have to plan a full day retreat. It doesn't have to be a meeting. It can be a very, very quick process. And if you think about it, we as humans do plan, do, study, acts all the time. We just don't define it that way. You know, I like to think of as a parent, I have young children, and getting to school on time in the morning can be a challenge. And my husband and I have gone through many PDSA cycles as we try to find improvements so that we can get out of the house on time and get to school before it starts. So maybe, hey, maybe if we try them sleeping in their pajamas and we take out that variable of the time it takes to get dressed, we can get to school on time and so forth. So we do that constantly, but we just don't define it that way. But again, if you think about that and make it very manageable, small bites, it's much easier for practices to get going. And you really don't want, this is also one of my favorite comics about improvement, that no thanks, you don't want that round wheel because you're too busy working in an ineffective and overburdened practice, when really, if you took that opportunity, implemented that strategy, things would work far more smoothly. So keys to success and quality improvement in clinical practices is you really want that change team to have key stakeholders. So you don't want to have a team, you implemented some changes, and then practice leadership or management gets hold of it like, no, there's no way we're going to do that. You don't want that work to be lost. So you want to make sure you have the key players at the table who can either approve or disapprove, but also have a key role in whatever process you're trying to impact. Remember that the data is for improvement and learning. It's not for research or accountability. So don't try to come up with the perfect measurement thing. Don't try to look at data for your whole patient panel. Don't use that data to punish someone for not doing a process correctly. Really look at just enough data to inform you and try to get it quickly and reliably, and always view it as a learning opportunity. If you do that, people will be far more willing to share successes, admit to mistakes or when they miss something, and you'll have a more positive, less fear-based improvement strategy. as you think about implementing changes to a system, you really want to think about prioritizing strategies. So a lot of times we'll think about, well, is there some low-hanging fruit? Is there something easy that can be done quickly so that the practice can see some quick and easy wins? Because nothing stimulates excitement more than some quick, easy wins. You don't want to start with your hardest, most challenging problem that people might struggle with for months and see very little or no outcome. So see, is there something that can be easily done? Is there something that you as an AFIX coordinator can help support practices implement? Do you have materials that they can use for patient education? And then really think about how you can translate your goals into actionable level items. We can all have great ideas, but if you can't translate that into action, they're really not worth pursuing. And then from the get-go, you want to think about, is this something that could be sustained? So think about, how would this be implemented into the whole, the group as a whole? How will it become part of our standard clinical processes? You don't want this to be a single individual who's passionate about HPV, making changes that impact, her patients, and then if she leaves the practice, all those improvements are gone. You really want this to be a system level changes. So I want to thank you all for listening to this training. We do have 2 other webinars in this series that we've developed for the Washington AFIX program, and that is strategies to increase HPV vaccination rates and tools and tips for working with clinical practices. Thank you for your time today.